with the topic of fetal circulation. So what is fetal circulation? When the child is in the womb of the mother, the lungs are not functional. So what is the source of oxygen for the fetus inside the womb of the mother? The source of oxygen is nothing but placenta, right? So the source of oxygen is placenta. When the child is in the womb, the source of oxygen is placenta. Through this placenta comes umbilical vessels. We have umbilical vein, we have umbilical arteries, right? Left umbilical vein is left, so we have a single umbilical vein and two umbilical arteries. We know that arteries usually carry oxygenated blood and veins carry deoxygenated blood. But the exception is two, umbilical and pulmonary. So here this oxygenated blood is carried by umbilical vein. And which umbilical vein? Left umbilical vein, left is left, right? So this oxygenated blood is carried from the placenta via left umbilical vein. Now this oxygenated blood from the left umbilical vein has to reach the entire body of fetus, and to reach the entire body of fetus, it has to reach to a pump. Which is the pump that circulates the blood throughout the body? That pump is the heart. So this blood from the left umbilical vein has to reach the heart. To reach the heart, it drains now to a vessel that drains into the heart. Which vessel that drains into the heart? It goes to the IVC, inferior vena cava. So this left umbilical vein, blood from this left umbilical vein goes to another vein, that is inferior vena cava. So through a duct. So duct joining the two veins, left umbilical vein and inferior vena cava, this is known as ductus venosus. Ductus venosus. And we all know this inferior vena cava will drain into the right side of the heart. So the right side of the heart is getting the oxygenated blood. What happens as soon as it reaches the right side? As soon as the blood reaches the right side, we know our body is going to get the oxygen from the left side. So most of this blood is going to be shunted out. Most of this blood is going to be shunted out through a shunt over here. This hole is known as foramen ovale. Foramen ovale. So about 1/3 blood will go down through this hole in between the two atria, right atria and left atria. This is known as foramen ovale. Now the remaining blood will go down into the right ventricle. From the right ventricle, it should go into the pulmonary vein. But in the fetal life, I told you the lungs are not functional. The pulmonary circulation has very high pulmonary vascular resistance. So what will happen? The blood won't go down because of the high pulmonary vascular resistance. It is shunted to the other artery. So from the pulmonary artery, the blood gets shunted through this duct. So a duct connecting two arteries, pulmonary artery to the aorta, big artery. This duct is known as ductus arteriosus. So this is the major fetal circulation that happens, right? So source of oxygen, placenta. From the placenta, oxygenated blood is carried by the left umbilical vein. This left umbilical vein joins another vein, that is inferior vena cava, that is draining into the heart. This two veins, left umbilical vein and IVC, inferior vena cava, is joined by a duct. So a duct connecting two veins is ductus venosus. Now this blood from the inferior vena cava goes into the right side. From the right side, some of the blood reaches the left side through a hole in between the two atria, that is known as foramen ovale. Rest goes down, but it does not go towards the lungs because there is high pulmonary vascular resistance. So that blood will be shunted again through a duct. So a duct connecting two arteries, pulmonary artery to the aorta, that is ductus arteriosus. So three fetal structures you need to know over here. First, this left umbilical vein. Second, this ductus venosus, foramen ovale, and ductus arteriosus. Now let's see what happens after birth. Post birth, what will happen? As a child is born, we cut the umbilical cord. So my left umbilical vein would be cut. So as soon as the left umbilical vein is cut, What structures will be collapsed? Left umbilical vein. So this structure, ductus venosus, will close. So this ductus venosus closes. Ductus venosus closes. Also, baby starts breathing. First cry of the baby happens after birth. As soon as the baby starts crying, the pulmonary vascular resistance decreases, right? So there will be a decrease in the pulmonary vascular resistance. That means the right-sided pressures of the heart will decrease. Right-sided pressures of the heart will decrease. RA-RV pressure will decrease, and also this ductus arteriosus, through which the blood was going from the right to the left side, now again will close because of the fall in their pressure. So here again ductus arteriosus also closes. And as the right-sided pressure decreases, left-sided pressures increase. And because of this change in the pressure dynamics, this fossa ovalis will also close. So there is closure of foramen ovale, right? So this is what is happening after birth, right? After birth, what is happening? This left umbilical vein is cut, so ductus venosus closes, pulmonary vascular resistance decreases. So what will happen? This ductus arteriosus will close, right-sided pressures will decrease, and the left-sided pressures will increase. So this foramen ovale will also close, right? So this is what they asked in the exam. When these structures close. So remember, most of these structures, the umbilical vessels, ductus venosus, ductus arteriosus, foramen ovale, they usually close soon after birth or at the time of birth. But ductus arteriosus takes some time. Ductus arteriosus takes 10 to 12 hours, 10 to 12 hours after birth to close. So 10 to 12 hours after birth. It closes 10 to 12 hours after birth. So these are duct-like structures, pipe-like structures. So what happens initially, they will collapse. So this is known as functional closure. And later on, this pipe, this hollow pipe would be converted into a ligament-like structure, a solid structure. That is known as structural closure. So initially what will happen? Only a functional closure will happen, and later the structural closure will happen. The duct will form ligament. The foramen will form fossa, right? So functional closure, you understand, happens soon or just after birth. Exception is ductus arteriosus. It takes some hours, 10 to 12 hours after birth. What about structural closure? Structural closure, if we talk about the umbilical vessels, they take around 5 to 10 days to close. Ductus venosus takes 3 to 7 days to close. Foramen ovale can take up to 3 months to years to close. And ductus arteriosus takes 10 to 21 days to close. And what would be the remnant structure? I told you duct will form ligament and foramen will form fossa. So left umbilical vein will form ligament, ligamentum teres, right? Ligamentum teres. Left umbilical vein, ligamentum teres. Ductus venosus will form ligamentum venosum. Foramen ovale will form fossa ovalis. Ductus will form ligamentum arteriosum. Right? So these are the structures. One-liners can be asked in the exam. Last structure to close functionally, we discussed ductus arteriosus. And last structure to close structurally, that's foramen ovale, right? So this is all about the fetal circulation that you need to know. So now let's move to the next topic, that is congenital heart diseases. And congenital heart diseases, we will stick to the important ones. Firstly, we are going to discuss the criteria. This is a clinical criteria that was earlier used so that we can suspect a child to be having as congenital heart disease. Now we have echocardiography here and there, but earlier it was not there. So we had certain clinical cues that used to tell us that this child could have a congenital heart disease. So this is what they ask in the exam. What is this NADA's criteria? So NADA's criteria, remember, has two criteria. There's major criteria and there's minor criteria. Okay, so in NADA's criteria, we have major criteria and minor criteria. What are the major criteria? Major criteria would be a diastolic murmur. Any diastolic murmur, if there, it is pathological. Major, any diastolic murmur. Any diastolic murmur. Second is if there is any systolic murmur of grade 3 or more. Systolic murmur grade 3 or more. Grade 3 or more. Right? Then we have congestive cardiac failure and cyanosis. So how you are going to remember these? Remember major criteria. Two criteria are murmur. Two criteria are murmur. Any diastolic, major, and systolic grade 3 or more is major. And the rest two are CC, congestive cardiac failure and cyanosis. What about the minor criteria? Minor criteria, systolic murmur grade 3 or more was major. So anything less than grade 3 will be minor. So systolic murmur less than grade 3 is minor. Less than grade 3 is minor. Apart from that, now all the investigations that we go for, routine investigation, if there is abnormal BP, abnormal second heart sound, abnormal chest x-ray, abnormal ECG. These are the minor criteria. And how many do we need to label it as a congenital heart disease? We need one major or two minor. One major or two minor. So they can ask you in the exam, write a short note on NADA's criteria. What is NADA's criteria? So NADA's criteria is used for the to label the child to be having as congenital heart diseases. We have major 4 criteria and minor 5 criteria. We need one major or two minor to label the child to fulfill the NADA's criteria, right? With that, let's come to the basics of heart diseases. So when we talk about congenital heart disease, the name itself has congenital heart disease. That means something that is present since birth. So mostly these are some structural problems with the heart that leads to issue. We have two types. We have cyanotic and acyanotic. Now let's look at this baby. This baby is pink. On the other this hand, this baby is blue. Cyanos means blue. So a baby can have a cyanotic heart disease or a baby can have an acyanotic heart disease. So in acyanotic heart disease, the baby is pink. On the other hand, in a cyanotic heart disease, the baby is blue. So why the baby is pink in one condition and blue in other condition? I know the left side of my body is going to give me oxygenated blood. If somehow the left side is receiving deoxygenated blood, the baby will look blue. So remember, normal heart, you all understand, we have the right side of the heart. We have the left side of the heart. Right side gets all the deoxygenated blood, and left side receives the oxygenated blood from the lungs and gives it to the entire body. But if due to some problem, what happens? This deoxygenated blood gains access to the left side. That means whenever there is a right to left shunt, there will be cyanosis. Right? On the other hand, if this is my heart, and due to some problem, there is left to right shunt. Left to right shunt. What will happen? Some of the oxygenated blood is going to the right side. Again, from the right side, the blood will go to lungs for oxygenation. So is there any problem that is happening to my body? No, my body will still receive oxygenated blood. Right? So this is acyanotic heart disease. So remember, whenever there is left to right shunt, there will be acyanosis, and whenever there is right to left shunt, there will be cyanosis. With this in background, let's move on to the first acyanotic heart disease that is important for your exam, that is ventricular septal defect. Right? Ventricular septal defect. So let's start with ventricular septal defect. Ventricular septal defect is a very common acyanotic heart disease. Acyanotic heart disease. What happens in ventricular septal defect? There is a defect in between the two ventricles. Can you see over here? There is a defect in between the two ventricles, the right ventricle and the left ventricle. So what happens as a result of this defect? Some amount of the oxygenated blood will go to the right side. Some amount of the oxygenated blood will go to the right side. So my pulmonary artery will receive some little more blood. So a little more blood will be over here as well. Right? This is the mitral valve. This is the tricuspid valve. So what will happen to the heart sounds? What will happen to the heart sounds in this condition? Heart sounds you all understand. We have S1, we have S2. What happens at the time of S1? S1 is due to closure of which valves? Due to the closure of these valves, right? Mitral and tricuspid valve. So what happens? There will be filling of the ventricles during diastole, and during systole, I need my mitral and tricuspid valve to close so that blood can go down into my aorta and pulmonary artery, right? So at the time of systole, these two close and form a S1 sound. And then comes S2. S2 has two components, A2, P2, right? Closure of the aortic and the pulmonary valve. So wherever there is some irregular flow or excessive flow through a valve, that sound is going to be abnormal, right? Now, whenever in heart diseases, we read about these sounds, we also hear some abnormal sounds apart from the normal sounds. What are these abnormal sounds? These are murmurs. So murmurs, remember, are of two types, shunt murmur and flow murmur. Flow murmur will happen whenever there is excessive flow through that state. Through that door, if there is extra flow, there will be murmur. So imagine there is a door. If earlier the water flow through this door was less, so what will happen when this door will open? Normal sounds will happen. But if suddenly the flow has increased through this door, so now when this door will open, the sound will be very loud, right? So through any valve, if there is excessive flow, during the time of opening of that valve, you will appreciate that murmur. So I know this valve closes during systole, and this valve closes during diastole. And when these valves open, whenever there is diastole, this valve will open. Whenever there is systole, whenever there is diastole, these valves will open, and whenever there is systole, these valves will open. So whenever there is high flow through pulmonary artery and aortic artery, there will be which type of murmur? There will be a systolic murmur. And whenever there is high flow at the tricuspid and the mitral area, there will be diastolic murmur. Understand? So let's look at the murmurs over here. First, the shunt murmur. What is the shunt murmur over here? What is the shunt appreciated over here? The shunt over here is in between left ventricle and right ventricle. Is the pressure difference between these two chambers high? Yes. So I will appreciate a continuous pansystolic murmur. And this murmur is so loud. That my both S1 and S2 are masked. These are masked by the murmur. Then comes the flow murmur. I told you excessive flow at the pulmonary artery and the excessive flow at the level of these mitral valve. Right? So at mitral and at pulmonary region, you are going to appreciate the flow murmur. When does the mitral valve open? Mitral valve open at the time of diastole. So in the mitral region, you will have a diastolic murmur, and pulmonary area, you will have a systolic murmur, ejection systolic murmur. Right? So this is how you appreciate the sounds in the murmurs. Remember, mitral and tricuspid, if flow is increased, you will only appreciate a diastolic murmur. Pulmonary and aortic, if flow is increased, you will appreciate a systolic murmur. Right? Now there are types of VSD, different types of VSD depending upon where the hole or defect is there. We have perimembranous VSD. In the membranous portion, if there is a hole, perimembranous VSD. Then we have muscular VSD in the muscular septum. If the hole is there, usually multiple holes are seen, and this is known as a Swiss cheese appearance. Swiss cheese appearance. Have you seen a Swiss cheese in Tom and Jerry? The cheese, right? Swiss cheese, multiple holes. Then we have inlet VSD and outlet VSD. It is just depending upon where is the position or location of this defect. Murmurs and sounds we have discussed. What is important are complications. What is happening over here? Blood is shunted from the left side to the right side. Now, if this happens, it continues to happen over time, what will happen? The right-sided pressures will increase and there will be reversal of the shunt. Now, the right-sided blood will go to the left side. And we all know whenever there is right to left shunt, whenever the deoxygenated blood gains access to my left side, what will happen? Cyanosis will happen. And this is known as Eisenmenger syndrome. Whenever there is reversal of this shunt to right to left, this is known as Eisenmenger syndrome. So the first complication is Eisenmenger syndrome. Eisenmenger syndrome. Second, because the pulmonary blood flow has increased, there are chances of infective endocarditis. And it is the most commonly encountered complication, complications, and the most common organism responsible for this is Streptococcus viridans. Also, because the pulmonary blood flow has increased, there will be pulmonary congestion. Lastly but not the least, this child can lead to congestive cardiac failure. So what would be the treatment over here? Firstly, let's talk about the medical management. If there is congestive cardiac failure, I need to give digoxin. For pneumonias, we add antibiotics. But the definitive treatment would be surgery. In surgery, we do patch closure. And what is the indication for doing this surgery? Firstly, if the pulmonary circulation QP/QS ratio is more than 2:1, then we go for surgery. What do I mean by that? Remember this diagram I told you? This is the pulmonary circulation. So when we do the echocardiography, this pulmonary flow is depicted by QP. Flow Q and P is pulmonary. And the systemic flow through the aorta is QS. So normally what should happen? This flow should be more so that there is left to right shunt and the baby stays pink. But if the pulmonary pressures are increasing, what will happen? Reversal of shunt will happen, Eisenmenger syndrome will happen. So on echocardiography, if you see that the pulmonary pressures are increasing too much, they have been almost double, 2:1 of the systemic one. It is a critical situation where Eisenmenger syndrome can set in and we need to go for patch closure. Second, if the child is in congestive cardiac failure, we go for patch closure. Now they ask, what is the contraindication of this patch closure? Contraindication is Eisenmenger syndrome. Once the Eisenmenger syndrome has set in, you don't do the patch closure. So if you do a patch closure in Eisenmenger syndrome, what will happen? This pressure dynamics have already changed, so this patch closure will fail. So contraindication is Eisenmenger syndrome. Once Eisenmenger syndrome has set in, you don't do the surgery. Right, so this is all about ventricular septal defect. So if they ask you about the short note, tell about the types of VSD, show this line diagram. Such line diagrams are also given in Ghai textbook. Tell about the heart sounds and the murmurs, complications and medical management, and lastly the surgical management. This gives you the overview of VSD. Tiny Tails Clinic is asking how to remember systolic and diastolic. Very simple. How would you remember? Normal physiology, you all understand. This is my right side of the heart. This is my left side of the heart. On right side, I have right atrium, right ventricle, and tricuspid valve. On the left side, I have left atrium, left ventricle, and mitral valve. What happens during systole? During systole, what happens? During systole, these are going to close. These are going to close and these are going to open. These are going to open. And what happens during the diastole? This will open and this will close. So whenever you are talking about flow murmurs, so flow murmur will be appreciated at the time of opening, right? At the time of opening, if the flow is high, I will hear a whoosh sound. So when these valves open, when a mitral and tricuspid valve open, they open at the time of diastole, and these open at the time of systole. So if flow is increased at the aortic area or the pulmonary area, I will appreciate a systolic murmur. On the other hand, if flow is increased over the mitral and tricuspid area, I will appreciate a diastolic murmur. As simple as that, right? So this is all about VSD. Now let's move to the cyanotic heart disease, that is TOF, tetralogy of Fallot. So tetralogy, you all understand, tetrad. That means there are 4 things over here. There is not a single defect, but 4 defects. What are these 4 defects? The first defect is pulmonary stenosis. The second is a ventricular septal defect, a large VSD. Then we have overriding aorta and right ventricular hypertrophy. So I have made a line diagram. Similar line diagram is given in Ghai textbook. So you see all the 4 things. We see a VSD over here. We see pulmonary stenosis. We see right ventricular hypertrophy and overriding of aorta. So what will happen over here? We know left-sided pressures are more than the right-sided pressures. But here, what has happened? My right-sided pressures have increased. There is pulmonary stenosis. So what will happen? More and more blood will stay over here. Right ventricular hypertrophy. So what happens over here? The deoxygenated blood gains access to my aorta. So there is right to left shunt. That's why there is cyanosis. So what are the sounds? What are the sounds over here? Firstly, S1, S2. S1, S2. So any problem in the S1, S2? No. Mitral and tricuspid, S1, no problem. So S1 will be normal. What about S2? S2. S2, see the pulmonary area. Pulmonary door is closed. Pulmonary door is narrow. So if a door is wide open and you try to close it, you will hear a louder sound. But if a door is very slightly open and you go and close it, the sound will be very soft, right? So here the pulmonary sound P2 is soft and delayed. Now let's look at the murmur. Firstly, the shunt murmur. Shunt murmur in VSD we studied, if the pressure between the 2 chambers is high, you will appreciate a shunt murmur. But here the right-sided pressures have also increased. So the shunt murmur here is absent. But do we see a flow murmur? Yes, we see an increased flow. We see a flow at the pulmonary region. So pulmonary systolic murmur is heard. Right, so these are about the murmurs. Now let's talk about the clinical features. The clinical feature, it is a cyanotic heart disease, so definitely there's going to be cyanosis, but this cyanosis takes time to set in. Usually it is seen after weeks to month, not since birth. And the second clinical features, which is the usual presentation in these children, is Tet spells. This Tet spells can be a short note too. Tet spells. What are the Tet spells? What happens if a child with the TOF cries or hyperventilate, or there is a period of stress, hypoxia? What will happen? This pulmonary artery, infundibulum of this pulmonary artery undergoes spasm. So that means this pulmonary stenosis worsens. So once this pulmonary stenosis worsens, what will happen? There will be more right to left shunt, more and more right to left shunt. So my body will receive more and more deoxygenated blood. The baby will turn blue. Baby will turn cyanosed. And this cyanosis in turn will cause hypoxia. In turn, that will cause progressively spasm. So a vicious cycle sets in. A vicious cycle sets in. This is known as Tet spells. So what happens in Tet spells? When the infant cries or hyperventilates, there's a period of stress, hypoxia. Because of that, there is going to be infundibular spasm. Fundibular spasm. And that leads to increase in the right to left shunt. That leads to cyanosis. The cyanosis will in turn lead to this hypoxia and stress. So there is a vicious cycle that sets in. Right, this is Tet spell. What is the treatment of this Tet spell? This is the initial treatment, squatting or knee chest position. What is happening as a result of squatting? When the child squats or there is the child takes up this knee chest position, what will happen? The femoral vessels, they will get compressed. So my femoral artery will also get compressed. My femoral vein will also get compressed. Now let's see what will happen because of that. When the femoral veins get compressed, what will happen? There will be less blood flow over here, less venous return. So less pressure over here, less flow over here. Right-sided pressures will be less. On the other hand, if pulmonary artery gets compressed, there will be increase in the systemic vascular resistance. So my right-sided pressures will drop. My left-sided pressures will increase. So the shunt would be reversed. There is reversal of the shunt. Right to left would be now less. There will be more left to right flow. So cyanosis will disappear. This is the mechanism by which squatting helps. So when the femoral vein will compress, there will be decrease in the venous return. There will be decrease in the RA-RV pressures. On the other hand, when the femoral artery is compressed, there will be increase in the systemic vascular resistance. LA-LV pressures will increase. And there will be now reversal of the shunt. There will be now left to right shunt. So as a result of that, cyanosis disappears. Right, simple. This is how squatting and knee chest position will help you in the situation of Tet spell. But the child cannot go on squatting and staying in that knee chest position for long. What is the medical management over here? What do we want to do? We want to increase the systemic vascular pressures so that the shunt is decreased. So in medical management, we have alpha agonist and beta blockers. Alpha agonist, we can use phenylephrine. Beta blockers like propranolol can be used. And temporarily, we can give this prostaglandin analog that is known as alprostadil. Alprostadil. Remember, this alprostadil will save the dill of the child, save the heart of the child. What this alprostadil or prostaglandin inhibitor will do? What is the problem over here? Right to left shunt is the problem. So what if I bypass this blood from the left side to the right side through a duct? Remember this duct in fetal circulation? This duct was connecting my two arteries, pulmonary artery to the aorta. What was that? A duct connecting two arteries, ductus arteriosus, ductus arteriosus. So normally in our body, PGE2 keeps this duct open. This is the normal. PGE2 keeps the duct open. So if I give a prostaglandin analog, PGE1, this will temporarily keep this duct open. So there will be left to right shunt. So this is a temporary measurement in which we keep the duct open so that there is slight left to right shunt. Final would be surgery. In surgery, we again want to make a channel connecting this pulmonary and systemic circulation. So we make ways in which pulmonary artery is connected to some systemic circulation vessel. The most common shunt that they ask in the exam is Belloc-Taussig shunt. In Belloc-Taussig shunt, you are going to connect this pulmonary circulation through subclavian artery of my systemic circulation. Second is Watterson shunt, in which ascending aorta is connected to your pulmonary artery. Then we have Potts shunt. Potts shunt. In this Potts shunt, you connect the descending aorta with the pulmonary artery. Right, so this is the management. Next, they ask about the investigation, the famous chest X-ray. What do we see over here? The boot-shaped X-ray. This is the typical of TOF, boot-shaped. Why this boot shape is there? Because of the hypertrophy of the right ventricle. So we see a boot-shaped heart. This completes a section of TOF. Whenever they ask TOF, tell about the tetrad, the 4 components, make this line diagram, tell about the sounds and the murmur, clinical features, Tet spell, explain the management of the Tet spell, and the surgery part and the chest X-ray, infamous chest X-ray. Now let's wrap up the session with the last topic, that is acute rheumatic fever. So acute rheumatic fever is one of those entity that happens post-infection, right? This happens with after the infection with group A beta hemolytic streptococcus. And the age group that is mostly affected is 5 to 15 years of age. What happens here? The child will have infection, sore throat by this organism, group A beta hemolytic streptococcus, and 2 to 4 weeks after that sore throat, the child is going to show you the features of rheumatic fever. What is the mechanism over here? The mechanism is nothing but molecular mimicry. Molecular mimicry. What is this molecular mimicry? So when the sore throat happened, the infection happened, the body of the child produced some antibodies. These antibodies were meant to kill that infection, but because of the similarity, because of the molecular mimicry of some antigens of that bacteria and the cardiac antigens that my body's antibodies are going to attack now my heart, right? So this is molecular mimicry because of the similarity of the molecules, similarities of the structure, similarity of the antigens between that bacteria and my own antigens. The antibodies that were initially produced to fight the infections will now fight self, right? So this is molecular mimicry. That is the mechanism behind this acute rheumatic fever. To study the acute rheumatic fever, to label the child to be having acute rheumatic fever, we have one criteria. This is known as Jones criteria. Jones criteria again has some minor criteria and major criteria. Firstly, let's talk about the major criteria. I have written Jones very dramatically. This is for you to remember the major criteria. J stands for joints. So major has polyarthralgia or arthritis or arthralgia, right? J is for arthritis, inflammation of the joints, or joint pain, that is polyarthralgia. In O, I have drawn a heart. This is for carditis. N is for nodules. They have subcutaneous nodules. E is for a particular rash that we see over here. Can you see the rash over here? The margins of these rash are red. Red means erythema and the margins are red. So this is known as erythema marginatum. Erythema marginatum. And lastly, S is for the chorea that we see over here. Syndendum's chorea. Syndendum's chorea. Right? Now let's talk about the minor criteria. In minor criteria, firstly we have your fever more than 38.5, more than 38, right? Then we have polyarthralgia, monoarthralgia. We have ESR and SRP. ESR more than 60 mm per hour or more than 30 millimeter per hour. We have CRP more than 3 milligram per deciliter and increase in the PR interval. Now you must be confused. That polyarthralgia was in major also, it's in minor also. And what are these two values of fever? More than 38.5, more than 38. What are these two values of ESR? More than 60, more than 30. So these criteria are based upon the incidence and prevalence of this conditions. So we have something that is known as high risk population, HRP. What is this high risk population? In high risk population, if the incidence of acute rheumatic fever in the school going of the age is more than 2 per lakh of school going children, or the incidence of rheumatic heart disease, these children with acute rheumatic fever, they have carditis. So in future, what can happen because of this inflammation, because of this carditis, they can have some valve problems in future, that is known as rheumatic heart disease. So depending upon the incidence of rheumatic fever and prevalence of heart disease, incidence of rheumatic fever will be in a school going population, prevalence would be in the normal population, right? So if the incidence of ARF is more than 2 per lakh of the school going children, and if the prevalence of your rheumatic heart disease is more than 1 per thousand population, this is known as a high risk population. So in high risk population, I have to be very cautious, right? My threshold for these criteria would be less. So in high risk population, I will take polyarthralgia also as major. Otherwise, arthritis is the major criteria. Similarly, in minor criteria, the fever degree would be less for me. And obviously, polyarthralgia is for the major in cases of high risk population. Mono will be minor. And similarly, ESR more than 30 would be for high risk population. Right? So for high risk population, the threshold would be less. So this was about the major and the minor criteria. Then comes the essential criteria. What is the essential criteria? I told you this rheumatic fever is happening post-infection. Infection has to be the necessity. It is the essential criteria. So essential criteria is nothing but the evidence that there was a preceding streptococcal infection. So what will be the evidence by my body? Firstly, ASO, anti-septal O. So antibody anti-streptolysin who, if the titer is high, that is suggestive of infection. If there is the positivity in the throat swab culture, if you take a throat swab culture and that is positive for the streptococcal, that is an evidence. And lastly but not the least, if there is history of sore throat, that is also considered as an evidence of preceding infection. So when will you make the diagnosis? We will need an essential criteria. Along with that, if it is the first episode, then I need 2 major or 1 major plus 2 minor. 1 major plus 2 minor. 1 major plus 2 minor. And if it is a recurrent episode, then again I need 2 major or 1 major plus 2 minor. Along with that, 3 minor. In recurrent episode, 3 minor will also make that diagnosis. Right? So this is the diagnosis. How will you treat? This is happening post-infection. Firstly, you have to give antibiotic like penicillin so that no further antibodies are formed. And to prevent that infection, I will need anti-inflammatory drugs like steroids, aspirin. So for firstly, we are going to give penicillin. We can either give a single dose of benzathine penicillin, or if the child does not want a single injection, we can go for oral penicillin, penicillin V. The dosage is 250 mg 4 times in a day. This we continue for 10 days. If the child is allergic to penicillin, the second alternative is erythromycin. The dosage is similar, 250 mg 4 times in a day for 10 days. And what about the anti-inflammatory drugs, steroids and aspirin? We continue that for 12 weeks. Continue this for 12 weeks. So this is the management or treatment. I told you this rheumatic fever patients will form rheumatic heart disease, have chances of forming rheumatic heart disease in future. So for that, we need secondary prevention. Prevention levels of prevention you have read in community medicine, right? We have primordial prevention, primary, secondary, tertiary. So primordial, when the risk factors are there, to eliminate the risk factor. Primary, to stop the disease to happen in first place. Secondary, to prevent the complications, and tertiary is for the disability and everything that is associated with the complications. So here I have the disease, the child has the disease, acute rheumatic fever. I need to prevent the further complication, that is rheumatic heart disease over here. So for that we need secondary prevention. For secondary prevention we go for drugs, these penicillin drugs. We have benzathine penicillin, oral penicillin or erythromycin. The dosage will be similar. This benzathine penicillin, the child has to come now every month, that is every 3 to 4 weeks, the child has to come to my hospital and get this injection. If the child's weight is less than 30 kg, I will give 6 lakh IU. If above that, I will give 12 lakh IU. Every month, the child has to get this injection. If the child does not want injection, then the child has to take oral drug, penicillin V. What is the dose for prevention? 250 mg twice a day, daily. This the child has to take daily. Again, if the child is allergic to penicillin, the second alternative we have is erythromycin. The same dose is there, 250 mg BD daily. Right? Now comes the duration for how long these drugs have to be taken. That depends upon the presence or absence of carditis. If there was no carditis, then you have to take these for the next 5 years or 18 years of age, whichever is later. What do I mean by that? I told you this rheumatic fever we see in 5 to 15 years of age, school going children. So imagine if the child gets this disease at 10 years of age, there was no carditis. So I have to give either for the next 5 years or till 18 years of age, whichever is later. So next 5 years, the child will be 15, but 18 years is later. So I will continue this for till 18 years of age. So whichever is later, you continue till that. Secondly, if the child has carditis, we give it for the next 10 years or 25 years of age, whichever is later. So take the same example, 10-year-old child. If the child had carditis, then 10 years makes 20. But 25 years is later. So you give till 25 years of age. Right? And lastly, the child has developed RHD. There is an established RHD or surgical management for the valve of the same. The lifelong these antibiotics have to be given, or till at least 40 years of age, these antibiotic for the secondary prevention has to be given. Right, so this is all about acute rheumatic fever. So with that, we have completed our section of cardiovascular system. We discussed about the fetal circulation. We discussed about important NADA's criteria. We discussed about 2 important heart diseases. One acyanotic, that is VSD. One cyanotic, that is TOF. And lastly, we wrapped up with acute rheumatic fever. If there is any doubt regarding any of these topics, then drop that down in the comment section. I'll be more than happy to repeat that topic again.